Welcome to The Art of Medicine, the program that explores the arts, business, and clinical aspects of the practice of medicine. I'm Dr. Andrew Wilner, and my guest today is Dr. David Weinstock. Dr. Weinstock is professor of medicine at Harvard University, a specialist in cancer care, and a researcher at the Dana-Farber Institute. Welcome, Dr. Weinstock.
Thank you, and thank you very much for inviting me.
Oh, it's my pleasure, and it was really the trigger here for this invitation was an article that you wrote in the New England Journal, published this month, November 2020, that really resonated with me. In fact, it's an article that I wanted to write 20 years ago, but I didn't have any credibility. I figured if I write that article, nobody's going to believe it and nobody's going to publish it. But then someone like yourself, who is in can I say it's sort of a member of the establishment, right? You're a Harvard
elite, I think is the term. Yes.
Yeah, I mean, you really are. And you're a professor at Harvard. You run I checked out your laboratory on the internet, I don't know, 20 plus researchers trying to cure cancer, right? And you've been in this business for a long time. And of course, you make rounds with the residents at the hospital to mentor them. But you had something very interesting to say that I thought was pretty courageous. And so I want you to start by just giving a little bit of your background and how you came to write the article, and just summarize it very briefly for those who haven't had a chance to read it. I'm going to post the reference here so that other people can read it later.
Sure. Well, the article is called "On Grieving for the Out of Practice," and the out of practice is me. And what it really is about is how to come to terms with the challenges of trying to do it all, trying to run a laboratory and train the next generation, and write, get funded, and so on, and while at the same time maintaining outstanding clinical skills. And realizing, in my case, and I want to make a really important point that it's not applicable to everyone, but in my case, I had become out of practice. And it was time to hang up my stethoscope. I started, my medical journey like everyone else in medical school, a little unsure of exactly what I wanted to do. And it wasn't until I was already through internship and residency and a fellowship, and then ready to decide about my scientific direction, that I decided to go into the laboratory. Ended up really loving it, did a very lengthy postdoc. And so I tell people the time from when I left for college to when I got my first job was 18 years. It's an incredibly long and intense training process to be able to, be a triple threat. But what I came to realize now, it's been 12 years since I came to Harvard, opened my group, increasingly focused on the scientific side, is that I just can't maintain those skills at the bedside. So, like I said, I feel out of practice, and I thought it was time to recognize it and stop seeing patients.
Right. So when I read this, I remember because I had a similar sort of beginning where I was interested in research. I wanted to teach. I wanted to take care of patients. And I did some research projects on the side when I was a neurology resident. And I just remembered they just took so much time. Often they would be incomplete by the time, I was sort of getting to the end. My rotation would change or my schedule would change, and it never got finished. And I very reluctantly admitted to myself that, I'm a really smart, intelligent, driven guy, and I can't do it. I just can't do it. It's never going to happen. And I felt like a failure. And those are the words that you used in your article. And I think, we sort of model ourselves after, William Osler, Dr. Penfield in my case, famous neurosurgeon, the guys who they did it all, right? They traveled all over the world. They worked in this lab and that lab. Dr. Penfield made the homunculus, in every textbook, and he cared for patients, even his own sister. And they were world renowned at everything. But, it's 2020, and the data input that you need to master to be a researcher, not to mention, I don't think people appreciate, my brother is a scientist at the Center for Astrophysics at Harvard. And he's a scientist, and the time he spends reviewing grants, applying for grants, I mean, that's his whole life. He doesn't have time to become a clinician, and people don't realize what's involved in getting a grant and being a scientist, or in your case, running a laboratory at the same time. All of these have become, even of themselves, more than a full-time job. Let me wager that your work week is longer than 40 hours. I'm going to bet dinner on that. Is that correct?
It is, but that's what we signed up for. And one of the really wonderful things about being a physician scientist is that there are many different ways to model your day, to model your career, and there's a lot of flexibility in choosing, where I'm going to focus, where I think I can have the most impact, where I get the most gratification. That said, it's exactly what you were talking about. That doesn't necessarily mean that you can be great at everything and do everything. And that's a really central point of the piece that I published, which is that discussion around realistic expectations and trying over the course of a career to understand, especially if there's data available, about how to craft your career to be most impactful and to get the most gratification. We're really lacking that. We don't necessarily talk to our trainees about their careers in that way. Instead, I think the term I said was, we tell them they can do everything well forever, and almost no one can do that.
Right. There may be a few sort of Leonardo da Vinci's out there, who just have the IQ and the bandwidth and the energy. I remember reading about Parkinson. Dr. Parkinson, who described Parkinson's disease, was an amazing guy. He had other interests in politics. He collected, I think it was shells. He had one of the world's biggest shell collections, from underwater. And they say when he retired, they had to hire 3 people, 3 neurologists to replace him. There are people like that. And it's, it's humbling when you realize, you're not one of them, that this is the exception and not the rule. But, I think your argument even extends to, I trained as an epilepsy specialist, and I worked as an epilepsy specialist for many years. And then I decided I enjoyed the new kind of profession of neurohospitalist. And I became a neurohospitalist and also work in the clinic. But even so I've kind of become a general neurologist after I trained as a subspecialist. But I'm even wondering, is it even possible to be a general neurologist anymore? When I trained, so in neurology, this is between 1985 and 1989, we treated patients with multiple sclerosis. We knew what that was. We had one treatment, which was steroids. That was it. Now I think we have 20. All of these treatments have different dosing, different indications, different side effect profiles. Patients have to be individualized. You can't just pick one off the shelf. You got to read the PDR. You got to figure out, is this appropriate for my patient? Is it the best choice? Similarly, even Alzheimer's disease, we have several treatments. You look at epilepsy, basically, and when I trained as an epileptologist, we used about 6 drugs. Now there's way more than 20, maybe 30. Again,
I completely agree. It's the same in oncology. I know you did locum tenens. I see emails about, come do locum tenens in Mississippi for a month. And I think to myself, how would I possibly take care of esophageal cancer or colon cancer or brain tumors? We used to joke when I was a trainee at Sloan Kettering that people were so specialized that you didn't just specialize in breast cancer, you specialized in left breast cancer.
Right.
And
it's the left breast or the right breast. You got to call the right guy, right?
Exactly. Exactly. So I found myself on the wards not only feeling like I was rusty because I hadn't rounded in 6 months, in the first place, but also just seeing that medicine was passing me by. And it doesn't happen the first time you take 6 months off, but the 10th, 12th, 15th time, now you're 9 years, 10 years into this, and you're hearing about tests or apps or drugs and so on that are just new to you, and even dedicating a lot of time to try to keep up. It's just not the same as being in practice. People who dedicate their entire professional careers to making sure they're providing the best possible clinical care.
So I'm going to extend, well, there's a few types. One, I'm going to extend this to the individual, man or woman, faced with this challenge who also wants to have work-life balance, because the amount of knowledge and skill that one needs to accumulate is now beyond what is humanly possible, right? I mean, you can go to the library. I mean, neurology, we used to have 2 journals. We had the green journal and the blue journal. And if you're really dedicated, you could get through most of the green journal, maybe half of the blue journal. Blue journal was research stuff, was kind of tough. Now 20 plus, 30 plus, 40 neurology journals. I'm lucky if I can just read the titles, never mind the articles in all of them. It's impossible. So, all right, well, why don't we just jump to the solution? What are you telling the trainees, who say, Dr. Weinstock, I want to do research. I want to take care. I don't really know which way to go. What should I do? I'm sure that, they look to you as a model.
Yeah, in general, I don't like giving advice because I think it's right about 50% of the time. I think that people are complex and their individual situations are complex. I ended up where I ended up because of many random things and many things that were beyond my control, like the fact that I was still relatively young. I didn't have debt. Those things are really important when someone's making a decision. That said, if someone is interested in a career as a physician scientist, I encourage them whole hog. I believe it's still the best job that there is, but it's a very long training process. So you've got to be in it for the journey, and you've got to get goosebumps every once in a while when you discover something that you realize this could impact people in a way. And I have knowledge no one's ever had before, right? There are no more continents to discover. This is discovery in 2020, and as exciting as it gets. Plus, there's the opportunity to see your discovery, maybe in a couple of years, maybe in 10, maybe more, actually positively impact human beings. If that gets you the goosebumps, then I think a physician scientist career is a great way to go. But what the piece is really saying is that those are serpiginous careers. They're not the career that Sir Osler had anymore. There are very, very few people who are going to be the department chair and the genius at the bedside, with a chain of 20 people in white coats following them, and publishing lots of papers in Nature and being in the National Academy of Sciences. What's more likely to happen is that you're going to have to make decisions as your career progresses, and that's a good thing because it implies a lot of autonomy, but it also requires you to recognize that you're going to have to give some things up, most likely. What I'm really pushing in the piece is that those decisions right now are really being driven by Gestalt. I go on the wards and I say, I'm not really sure I should be doing this anymore. And then I keep doing it for 2 more years before I finally say, well, no, I should stop now because it's COVID or because they're putting in a new EMR system or something and I don't want to learn it or something like that. If I had more structured information that could help me make those decisions, then I think I would have made a decision more quickly. I think I would have made a more informed decision. And I think it would have overcome a lot of those issues of feeling like a failure, that you were talking about. This is the expectation. This is the data. This is the way we think about progression of those careers. Is very, very different than I'm going to quit because I'm a failure, which is really how I felt about it.
Right. I want to ask you, when I was contemplating writing something like this, I thought, I'm going to admit, in public that I can't do it, that I'm an inferior being, because there are those beings, like David Weinstock, who can do it all. And, that's the model. So did you have any hesitancy to sort of bring all this out into public?
So I've thought about that. I didn't have a tremendous amount, and I think there are two reasons. One is, being totally immodest. I'm in a good place in my career, right? I'm a chaired professor. I'm well funded. I have remarkable trainees and already a cadre of people who I trained who are running their own laboratories, and we're doing really good science. And so from that position, it's a lot easier to say, but I'm not good at this, right? If I was struggling, I don't think I would have had the overall ego to be able to do it. The second is that I have wonderful colleagues here. And I'm not just saying that. I will say, when I moved from New York to Harvard, people told me, oh, you're going there, they're going to eat you alive. It's, they'll stab you in the back and leave you for dead. And it's just not true at all. So I have wonderful colleagues, and we do talk about these kinds of things. I don't think that my clinical colleagues think I am a great doctor. It's not like I was telling them something they didn't know, because I've been leaning on them for years. And I'm sure every once in a while I lean on them and they help me and they're nice. And then I get off the phone and they must think to themselves, this guy really should know that. So I didn't feel like I was really exposing something that wasn't already out there.
In a way, this is good news for everybody. There is so much science. There are so many new developments in clinical medicine that it is important to have people who keep up, that people are better served, by clinicians who are 100% devoted to. I loved what you wrote where you said great artists obsess over their work and that medicine is an art. And I think that's 100% right, is that if you're not obsessing over what you're doing, then you're not doing it as good as possible. I think it's an argument why the 100% clinician maybe the family practitioner should be getting more respect, and more realization that this is really a hard job.
I could not agree with you more. I absolutely could not agree with you more. I have tremendous respect for my clinician colleagues. And I also mentioned that I think in a way, stepping back from the clinic is an acknowledgement of that, right? That what they're doing is really hard and I'm not doing it as well as they can. I think the other point that's important to stress is, I also said I really believe in people training as physician scientists, because I do think there's a value in spending a lot of time at the bedside while you're also doing science, because you see problems and you can focus your research on what are the really important problems. I certainly worry that by stepping away from the bedside, I'm going to lose some of that perspective. I received, a lot of emails from people I do know or people who I've never met about the piece. And that was something that many people came back to over and over, was about how, you can go to clinical conferences, you can go to meetings, you can read up to date, you can do all these things, but there's really no substitute for time at the bedside.
I agree. And I want to use this opportunity to invite you to come to neurology rounds in Memphis, where I'm an associate professor, and heavily involved in the clinical aspect of patients. And you can round with us whenever you want to be at the bedside, if you want to take that opportunity, whenever you feel you're too distant. I know you have many opportunities there in Boston, but
yeah, we have something that's sort of an intensive teaching service that's usually a small number of house officers and 2 or more attendings. And I thought about whether I should look into something like that. There I could learn quite a bit about clinical medicine, and there's more time per patient, and I could continue to see patients without worrying that gaps in my knowledge are going to result in gaps in care. Of course, most people don't have those kinds of opportunities. Most people are spending too much time thinking about RVUs or getting their next grant or things like that. But I do have that opportunity, so I may take advantage of
Dr. Weinstock, I want to thank you for bringing this topic to our attention, for publishing your really personal and thoughtful article, and sharing your views of where we are in clinical medicine and research in 2020.
Dr. Wilner, thank you so much. And thank you for this Art of Medicine series. It's exactly what we need to, I wouldn't say heal the soul, but nurture the soul of practitioners in 2020.
Well, thank you. I really appreciate that.